let me now turn to Esther Krofah, who is going to take us into a different angle on health equity, and particular focused on the biomedical research enterprise. Esther, thank you for joining.
Thank you so much. Okay, hopefully everybody can see this. Thank you so much, Sarah. Thank you so much to UC Irvine for inviting me. I'm delighted to be here and to be part of this panel conversation. My talk is going to focus on diversity in clinical trials, but I would like to start off by talking about where we are in our healthcare system. So when we talk about diversity in clinical trials, we need to remember that it's situated within a biomedical innovation ecosystem, which itself is situated within our healthcare landscape writ large. To point out, it's clear that our healthcare system, particularly here in the United States, it's fragmented, it's siloed, and it's expensive. When we look at the data, it's clear that within OECD countries, the US spends twice as much on average in terms of healthcare. However, we have not the same quality and outcomes in our healthcare systems. Americans still experience the worst healthcare outcomes compared to our peers in OECD countries. And further, when we look at the burden of disease in our country, we also have the highest burden of disease, particularly in chronic diseases and obesity, which again are higher on average in terms of our peers with OECD countries. And that is certainly the case when we look at our clinical trial enterprise as well, in that although we spend the most in biomedical research, and it certainly is a bright spot when we look across peer countries in our medical research ecosystem, we have the highest level of investment in basic science, the highest level of investment that we see in private spending on innovation. However, our biomedical innovation ecosystem is fragmented, it is inefficient, and it is siloed. And this, of course, translates in terms of how we see clinical trials occurring across the country. When we look at this map, which is provided at clinicaltrials.gov, and there are many other similar types of map that looks across our biomedical innovation ecosystem, what we find is that we have a lot of our clinical trials that occur in academic research institutions around the country, but they're not necessarily occurring in community-based settings. In fact, 70% of the population, it takes 2 hours or more to reach a clinical trial site. There are barriers in terms of establishing new clinical trial sites across the country, but currently the way that our clinical trial enterprise is organized across the country really are in these centers of excellence where the vast majority of individuals did not have the opportunity to participate. COVID-19 has highlighted, of course, these challenges in clinical trials and our medical research ecosystem. Of course, we saw the disproportionate outcome in terms of deaths related to Black, Hispanic, Latinx, and other minority populations. You see some of that data here. That disproportionate outcome, particularly to these minority groups, really led a focus in identifying and talking about what are the root causes, what are the challenges that these communities are facing, and reinforce the need to make sure that communities that are experiencing the disproportionate impact and burden of disease are included in medical research and trials that are able to yield potential therapeutics and vaccines. That led, of course, to the US government through Operation Warp Speed and the work that was happening at NIH to ask the companies that were focused on the COVID-19 vaccine trials in particular to slow the enrollment in those trials to recruit more minority participation. The concern, of course, was that if we did not include more minority participation in those clinical trials, if those clinical trials did yield vaccines or therapeutics that were safe and efficacious, there would be concerns in terms of their uptake among those populations who did not see themselves necessarily represented in those clinical trials. And quite often, the clinical trials do not represent the populations that do bear that burden of disease. And we see that across a whole range of different disease conditions that I'll talk about in just a moment. This, of course, comes out of decades and decades of what we will like to say are systemic unethical treatments of minority communities. For example, we know still today that African-American patients are not necessarily treated equally relative to pain, for example, as white patients. For example, we still have implicit bias in our healthcare system, and quite frankly, a lack of understanding in terms of the biology that may lead us to inaccurate conclusions about how various populations relate to their disease conditions. When we also look across the payer landscape, the fragmentation that we see in our healthcare system from a biomedical research ecosystem is reflected in the way that we pay for care. When we talk about participation in clinical trials, we have seen a number of policy changes and mandates and the like in terms of how Medicare, commercial and private payers and Medicaid pay for the routine costs that are associated with those who participate in those clinical trials. Most recently, Medicaid did add a policy and provision that was part of the Relief Act passed by Congress last December 2020 that begins in January of this year that allows participants in the Medicaid program and clinical trials to be reimbursed for routine costs as part of that participation. That was not there before. And of course, we know that a lot of minority populations, those who have lack of access in terms of care, that would obviously create a barrier in terms of accessing clinical trials. And when we look across different disease conditions and the clinical trial enterprise, the vast majority of participants in clinical trials are still underrepresented from the minority perspective. When we look at the FDA drug snapshot from 2015 to 2019, 78% overall of those participants in the US population were white. And we do not necessarily see those equivalent numbers, again, why the burden of disease across these conditions that are quite common, including cardiovascular disease, stroke, diabetes, and oncology in particular. When we think about oncology across all the various cancer conditions, African Americans, Hispanic are significantly underrepresented. In some cases, only 4% or 5% of those who are in those clinical trials. However, they experience really the worst healthcare outcomes in terms of their cancer conditions. So when we talk about what do we need to do, we know what the challenges are. We know that these challenges are historic. We know that they've been longstanding. We, of course, have a renewed commitment coming out of COVID-19 to look at these sets of issues. What we have been doing in our organization over the last year is really to provide greater focus in very specific sets of recommendations, what we can do to achieve greater diversity in clinical trials. And we know that this is also a priority for many other organizations as well. We released a report in November of last year. I provided the link to that report here that outlines very specific action steps and recommendations for how we can achieve diversity in clinical trials across the ecosystem, which is not monolithic. The ecosystem consists of both the federal and regulatory agencies, academic research institutions, biopharma, nonprofit and private research funders, the CROs, the clinical research organizations, where a lot of the sites that are activated come through that particular pillar, patient organizations and disease foundations, and certainly community health organizations as well. So that report lays out very specific steps that we can take across all of these various entities to ensure that we can achieve greater diversity, because it's really against the whole, not just any individual pillar. I did want to highlight some of those select recommendations here for how we can move the needle forward. From an engagement perspective, we need to understand where the lack of accessibility in clinical trials are. We need to fund expansion of community-based clinical trial sites. We need to connect both the delivery of care closer to clinical trials and where clinical trials occur, or activate new sites to participate in those clinical, in the clinical trial enterprise. From a funding and data collection perspective, we just heard again, the lack of consistent data that we collect across all of the clinical trials in the country. We have a data issue, data gap issue. We can address this in terms of the data that FDA collects from a regulatory decision perspective, but also the data that is required as part of an NIH grant or part of a PCORI grant, et cetera, to make sure that we're collecting data that is focused on race and ethnicity. We do collect data on gender. We do collect data again, on geographic basis, but we don't really do a great job of collecting data on race and ethnicity. And from a private investor perspective, there are tools that we can leverage, such as ESG criteria, to ensure that we're adequately incentivizing companies who are conducting clinical trials and are receiving funds from the private sector perspective to ensure that really are achieving metrics that we all care about, including equity. From a workforce perspective, we need to make sure that we're bringing in other kinds of healthcare workers and leveraging community health programs, leveraging community health workers, promotores, and others to really help with the patient navigation in terms of how they can find out about clinical trials, how they can leverage clinical trials, and to guide them through that entire process. And then certainly from an accountability perspective, we need to make sure that clinical trial sites are able to implement various procedures. They're able to provide and bring in patient advocates and community engagement methods into the entire ecosystem. Institutional review boards is yet another opportunity to ensure that there's accountability. Quite often we find with institutional review boards that make decisions about the design of a clinical trial, we need to have better diversification in who those representatives are in those IRBs. We do have a number of efforts underway, and this is really where I would like to end the conversation and open it up for the dialogue and the questions that will occur. I am very optimistic and encouraged by the level of engagement that's happening at the federal level through Congress, but we also know that there are efforts that are happening from the administration, and Dr. Seshimani talked about CMS. There are also, of course, lots of activities that are happening through organizations, through companies, and private sector driven initiatives as well. I did want to highlight these three proposed legislation for all of you to be aware of. The first is the DEPICT Act that was introduced early this year by Representative Anna Eshoo, Representative Fitzpatrick, Representative Kelly, that really focus on addressing some of those issues that I talked about earlier, such as enhancing the data collection, the requirements, demographics, as well as providing support to those local organizations through grants and workshops and trainings that can improve access to clinical trials, particularly in those community-based settings. Another piece of legislation, the Diverse Act, again, similarly, is trying to achieve those same goals, particularly making sure that HHS can provide grants and or contracts to enable education and outreach and recruitment for clinical trials, particularly for those who are disproportionately impacted in different disease states. And finally, the 21st Century Cures Act 2.0 builds on the 21st Century Cures Act that passed in 2016. This is being reintroduced by Representative Diana Daggett and Fred Upton that focuses, in addition to a number of other provisions and topics such as ARPA-H, requires greater diversity in clinical trials, particularly, again, leveraging the role of FDA to make sure that the new drugs that are being reviewed and approved are safe and efficacious for the diverse populations that are disproportionately impacted by various disease states. These are just a sample of the kinds of congressional actions that are occurring on this issue. But again, there are a number of initiatives that are happening from companies themselves to achieve these goals. I'll probably like to close out by just talking about the fact that when we look across all of our various roles, and those who are listening into this conversation today, that everybody has a role to play, whether in reviewing issues such as implicit bias, whether it's reviewing issues such as providing patient advisory councils to inform the design of a clinical trial, or in working on issues such as infrastructure and how we start new clinical trial sites. All of these can really help address this issue of diversity in clinical trials and really help us to take what we see as pilots and really make it a broad representation that's happening across the ecosystem, not just individual initiatives. And I'll turn it back over to you, Sarah. Thank you.
Thank you.